Well, I'm here with Adam DeVore from Duke University. He just presented the late-breaking study findings from the CONNECT HF trial. Welcome, Adam. It's so great to have you here. Could you start off telling us about the CONNECT heart failure study? Why did you do this study? What was the motivation behind it?
Absolutely. And Larry, thanks for having me on here. I really appreciate it. As you know, there's a large gap between what we know we can accomplish in clinical trials and what we can accomplish in clinical practice in heart failure with reduced ejection fraction. And I think one great example of that are some of the publications out of CHAMP-HF, where we see these very low rates of medical therapy for heart failure, low use, and then low dose titration. And so CONNECT-HF was designed to try to address this problem and really try to put some high quality evidence around different quality improvement strategies to improve this issue. It was designed as a pragmatic trial. It was a prospective, it was a cluster randomized trial where the unit of randomization was the hospital. And we randomized 161 hospitals in the US to either a new intervention or usual care.
Could you tell us details about that intervention? What it involved? What were the hospitals doing? How did you get it implemented?
Yeah, so if you look at the lay of the land in the United States, most hospitals have some type of quality improvement program. A lot of times that's focused around readmissions, but there's infrastructure there. And so our idea was to try to work with those people and really try to extend the intervention through the rest of the heart failure patient's journey out into the clinic and where they receive the rest of their care. And so we used the intervention was a little bit different at each site, but the backbone of it was audit and feedback, where we gave the hospitals high quality data around how their patients were doing in terms of quality metrics for heart failure, things like use of guideline directed medical therapy, and then the outcomes of the patients they were discharging. So audit and feedback, and then education. And we paired that up with a group of experts we called the CONNECT HF Academy. And so those were the two main things. And then hospitals were allowed to do individual quality improvement issues at their hospital too. But that was the backbone of the intervention.
Great. So you had 161 hospitals. Half of those hospitals were randomized to this intervention. Could you tell me about how many patients were enrolled total? And then discuss what did baseline guideline-directed medical therapy look like coming into the study?
Yeah, so from March 2017 to May 2020, we randomized 161 hospitals, and the effect of the intervention was measured in patients that consented for follow-up. So the intervention could have actually happened to all or most of the patients there at the hospital, but we actually measured the effect in those who consented for follow-up. And we enrolled 5,600 patients for follow-up, which is a ton for a U.S.-based heart failure study. So congratulations to all the sites and all, a recognition of all the hard work that they did. And we followed patients for the next year, and we were specifically following them for changes in medications, but also clinical events that happened. And the two primary endpoints were those things. One was heart failure rehospitalization or death, and the second co-primary endpoint was change in a quality score. You asked a little bit about some of the baseline quality of care that patients were receiving. And what we saw in CONNECT is that the use and dose of medical therapy for heart failure was, again, very low. In fact, it looked a lot like what we've seen before in CHAMP-HF. We did a composite quality score where we looked at the number of times a patient hit the recommended heart failure care and divided by the number of times they had an opportunity. So, for example, were they on an evidence-based beta blocker? And both in the intervention and the usual care, it was around 40% of time that the patients started off in the trial with the recommended care.
So you followed these patients out for a year. Could you tell me the top-line findings from the study?
So we had two primary endpoints here: time to first heart failure rehospitalization or all-cause mortality. And unfortunately, we saw no difference between the patients in the usual care arm and those in the intervention here. And in fact, the two curves nearly overlap, and the difference was not statistically significant for the clinical endpoint. For the quality endpoint, we again used this composite-based score, and we saw small changes in terms of the quality of care, but not meaningful changes like we were hoping to see. So just to give you a sense, I told you that in the usual care arm, patients had a score of around 45%. That actually decreased by 1% over 12 months. And then in the intervention arm, it was 42% and went up by 2.3%. So small changes, not the large changes we were hoping to see, and those differences were, again, not statistically significant.
Wow, sobering. We'd all like to see better therapy applied to our heart failure patients who have reduced ejection fraction, new therapies out there, lots of opportunities, a lot of work by your team, and really small changes. So what do you think this means, and what do we do next?
I think there are a couple of really important takeaways from this study. One is it's really important to study these things in a rigorous fashion, right? So we set up a cluster randomized trial to try to see if this works. And I think if you had asked me a few years ago what we would see here, I was very confident that this was really going to move the needle in terms of heart failure care, but we didn't see that here. And so I think, we have to remember that lesson that, applying high quality study designs is critical here to understand what works. The second thing is, I think we can safely say we answered the question. Interventions that are based on audit and feedback and education back to the hospital really don't change the needle above what we're already doing. I mentioned this earlier. We're doing a lot already in terms of quality improvement in the hospital, and so this isn't going to take us to the next level. And so I think we have to start thinking about what's next.
Good. And what do you think is next? I mean, do you have ideas? Are there things that you've seen on the horizon that are exciting to you? Where would you pivot as a trialist who's doing pragmatic studies like this?
Well, one thing I mentioned is that we really tried to tap into the quality improvement programs in the hospital. And, I think that things that we learned through this process is that we need to be thinking about what's happening in the clinics as well. And so I think quality improvement programs there are essential. But I think we also need to really kind of take a different angle on this problem. And I think your work is really influential here. The EPIC-HF study is a great example of trying to take something, go right to the patient and, prime their interest before they come to the clinic visit with a digital intervention. And you guys had great results there. And so I think that's, a new strategy. We need to be thinking about different things there. And then I'm very optimistic about other technology-based interventions that can go right to patients and families. I think that's another way to try to deliver care outside just the traditional walls of the hospital and the clinic.
We need to think about not only how to integrate the care across silos, so from the hospital to the clinic, even the community, but we really need to think about how do we engage patients and family members and community members, because providing healthcare for chronic disease really does require a team approach. Well, congratulations on completing this study. I know Connect Heart Failure was an incredible amount of work, and even though the findings were negative on the top line level, I think that what we've learned here is incredibly important and has real applications to the way that we move forward and what we do, not only in the hospital, but in the clinics with our patients. So thank you again, Dr. DeVore. Congratulations. And we look forward to what the next step is.